welcome to the third and final video covering Chapter 6. So let's get started right away. Okay, so we've mostly talked about epidermis and dermis, so we're going to switch gears, talk a little bit about hair, and maybe a little something about nails. All right, so hair and nails really are just heavily keratinized cells. And what you see on the surface superficially is all dead cells. Not much on this slide outside of that. And then, you know, in the hair and nails, the keratin is a little bit different. It's just a different form of keratin that's more compact and more hard. And so that's why the hair and nails are going to be, you know, not quite as soft compared to skin. Blackboard Collaborate is being really slow today. I'm trying to go to the next slide here. Hello. Okay. So hair. All right. Again, dead keratinized cells. It's just that it's a different kind of keratin. It's sometimes referred to as hard keratin. And you know, it's just a tougher form of keratin is all we really need to know about that. So what about functions of hair? There are a lot of functions, so you should be familiar with the functions. All right, hair does help warn us of bugs, insects, whatever that gets on the skin. You can feel that, you're alerted to it. And also hair helps guard us. It does serve sort of a protective role a little bit from physical trauma. It helps protect from heat loss. It does help a little bit to shield from the damaging UV light. Eyelashes protect the eyes, all right? And yes, hairs of the nose. We all have nose hairs, and it's good to have a little bit of that because it does help filter out certain products coming from the atmosphere. Hair is also known as pili. Well, pili is plural, all right? If you wanted to refer to a single hair, you would say pilus, P-I-L-U-S, okay? But hairs are also referred to as pili. And hair is produced by hair follicles, which are embedded deep in the dermis. So a little bit about the anatomy. You may just get like one basic question about the anatomy of the hair. So you have a shaft and a root. The shaft is the portion that you can see outside of the body. It's above the scalp. At this point, keratinization is complete in the hair. And you have a root. The root is the part within the scalp, or deeper, the part you cannot see. And this is where keratinization is still going on. You have a hair matrix. Now, the hair matrix is sort of comparable to the stratum basale of the epidermis. This is where the stem cells for hair cells are located, all right? And very similar to what you see in the epidermis, you'll see that these stem cells are producing new hair cells, and those new cells are going to be pushed up superficially, pushing off the older ones. So again, remember, we do, in addition to shed skin, we all do shed hair. Erector Pili. So Erector Pili are these really interesting little structures that you're going to find attached to the base of the hair follicle. And so the Erector Pili is basically smooth muscle, okay, that will contract when you're cold. Remember that when we're cold, we have muscle contraction, skeletal muscle contraction. Well, you also have the contraction of this smooth muscle at the base of the hair follicle. And so when you're cold or you get a chill, that's why you get these goosebumps, all right? The hair will basically stand up straight. It will be erect, all right? So that's something to keep in mind there with that. Hair papilla. So the hair papilla is comparable to the dermis of the skin, all right? The hair papilla is where we find all of our blood supply that provides nutrition to the hair. You have a hair follicle receptor, which is also called hair root or root hair plexus, and this is basically just a collection of sensory nerves that are going to be wrapped around the bulb of the hair follicle, and it's just a sensory touch receptor. So this is sort of a picture of all this, all right? So we've got the base of our hair follicle down here, all right? And so here in the middle, you'll find the hair papilla. Remember, that's comparable to the dermis, all right? It's basically very similar to that. It's going to be where you find the blood supply for the hair. Around that, just around the boundary of the papilla, you find the hair matrix. So remember, the hair matrix is similar to the stratum basale of the epidermis. That's where the stem cells for the hair cells are going to be. And of course, you find melanocytes. Your melanocytes will be situated around the stem cells in that hair matrix. All right. You know, that's basically it. You don't really need to know all these other parts here, okay? Keeping it pretty basic when it comes to the hair. Here's another picture of it, all right? On the right, you can see a histological view of this hair follicle, all right? And then, you know, another picture. And so what you can see here on the left is we have here a Erector Pili, okay? So notice that this Erector Pili is attached to the hair follicle, all right? So when this Erector Pili muscle contracts when you're cold, all right, it causes this hair to stand straight up. What else do we see attached to that hair follicle? Remember, they have sebaceous glands attached to the hair follicle. We're going to talk about those here in a minute. We also have sweat glands, but remember, sweat glands are not attached to the hair follicle, okay? They're going to go straight up out of the, and secrete directly out of through the epidermis. So a little bit about types and growth of hair, all right? You have a lanugo coat, which is basically considered the fetal hair, all right? So when you're a fetus, you have this very fine, delicate hair, all right, as a fetus. The lanugo coat. The lanugo coat is eventually shed, all right, and now develop vellus hair, which is also fine, okay, it's thin and fine and typically pale, all right, vellus hair. Doesn't have to be pale, but it is delicate, fine hair, not as delicate as what you see in the lanugo coat with the fetus. At this point, the hair is maturing a little bit more, and this is called vellus hair. And so this is what we see in children and also females, adult females. Okay, so adult females tend to keep this vellus hair. All right, so the vellus hair will replace the lanugo coat. And then again, vellus hair we'll see in children and adult females. Terminal hair is the coarse, long hair that's usually darker. And this is the kind of hair that you find on males, adult males. Now, in some places, females will also show terminal hair, but you'll notice, you know, on adult males versus adult males do have the hair on their body is a little bit more coarse, and so yeah, but this is called terminal hair. Now, we do find this in the scalp as part of the scalp and eyebrows, and at puberty is when you start to see this terminal hair appear. And it will first start to appear in the axillary and pubic regions of both male and female. All right, and on the adult male, this is the kind of hair that develops face and the neck. All right, these numbers you're not going to be asked about, just, you know, out of curiosity if you want to know that. All right, and again, like skin, we do shed plenty of hair as well. As far as hair pigments, okay, very similar to our discussion of pigment in the skin. All right, we're going to have melanocytes in the hair that are responsible primarily for hair color. Okay, so it's going to be about how much melanin is made. All right, if there's a lot of melanin made by that individual, they're going to have darker hair. If they don't make very much melanin, they're going to have lighter hair. And then, of course, you know, there are different kinds of melanins, all right? Don't want to get too big into this, but there are different kinds of melanins that vary in color. They range anywhere between like a yellowish red to brownish black, all right? And so these different combinations of these melanins will make a contribution to, you know, what the hair color is, all right? So red hair has a special type of melanin called pheomelanin. Brown and black hair is rich in the eumelanin, which is basically the melanin that we've been talking about long. All right, blonde hair is going to have this intermediate sort of melanin between pheomelanin and eumelanin. And how do we get gray hair? So gray hair results from, is associated with aging, right? So why do we get gray hair? Because melanin production decreases over time. Remember, again, the general rule with aging is that everything slows down, all right? Everything decreases, everything. So no difference here, all right? So this is why we get gray hair, because melanin production decreases. So a little clinical fact here, something called hirsutism. Hirsutism is referring to excessive hair, okay? And it's actually going to be a symptom of certain conditions, all right? Certain types of pathologies are associated with this masculinization, all right? And part of this masculinization is seen as hirsutism. Now, of course, we're going to see this symptom predominantly in women, all right, in females. And how is this caused? Well, some drugs can actually, treatments as drugs, some of these can actually cause a little bit of hirsutism. But primarily, you're going to see this in association with tumors, okay, tumors that produce male tumors in areas where we're producing androgens, okay? So androgens are the male sex hormones. But keep in mind, women also make androgens, okay? Females also have testosterone, all right? Yeah, females, there is a physiological use for testosterone in females as well, all right? It's just that females don't make as much testosterone as males do, and that's the difference. So, but you may have a female who develops a tumor in a gland, okay? The adrenal gland. Remember, the adrenal glands are right superior of the kidneys, okay? And so the adrenal glands are a location where you're going to produce androgens, all right? Ovaries too, okay? But primarily you're going to see this in an adrenal tumor, okay? A female that has an adrenal gland tumor is going to be making too much testosterone, for example, and this is going to result in a masculinization, all right? So this person might even develop like a deeper voice and just, sort of have more masculine characteristics. And you'll also see this as hirsutism as well, where the female will have excessive hairiness, okay? And in any case where there's a tumor, all right, any case where there's some kind of cancerous tumor, the treatment is removal of the tumor, always, right? How do you get rid of it? Here's the point I want to make on this is that, yeah, with a lot of different tumors, you're going to have a wide variety of symptoms depending on what the tumor is, right? So like in this example, if you have an adrenal gland tumor, what is a symptom? Well, hirsutism and masculinization. So the idea is you don't treat these symptoms. Okay, if we are dealing with a tumor, you do not treat, you don't try to get rid of the hirsutism, all right, or whatever other symptoms the person has. The first thing you do is get rid of the tumor, right? If you get rid of the tumor, then you get rid of the side effects of that tumor or the symptoms of that tumor, okay? So that's always something you want to do. You don't really treat these symptoms, all right? You just get rid of the tumor. And by doing that, you get rid of all these other issues associated with it. Hair thinning and baldness. Alopecia is referring to hair thinning. And in both males and females, this can be seen after the age of 40. This is typically normal, all right? It is normal for people over the age of 40 to have a little bit of hair thinning. It might be more severe in others and less severe in other people. All right, now what about baldness? Okay, something called true baldness or frank baldness. This is different. Okay, so baldness is genetically based, It's also gender-based, all right? Something called male pattern baldness. So this is a kind of baldness that is restricted to males, and it takes on a specific pattern, all right? What will happen is that first, the male will start to lose hair anterior, all right? So sort of in the front, okay, in the frontal region, they're going to start to have like a lot of people call a receding hairline, all right? So it begins there, all right, and then it will sort of spread to the top. So like in the parietal region, right, of the head, basically, all right? So you'll then start to see it at the top. All right, only thing about this is that you should know that this is caused by a faulty response. There's a problem in their follicles response to a chemical called DHT, and you should know what that stands for, dihydrotestosterone. So dihydrotestosterone is a precursor to the synthesis of testosterone. And the hair follicle in the male has a faulty response to this, right? So that basically it stops, the follicle stops producing hair because it's not really responding to this DHT. And some of the treatments out there for male pattern baldness, DHT is a target for that drug. Yeah, not much more about that. Just be aware that DHT is the issue there when we're dealing with this male pattern baldness. Hair thinning, again, so, there are lots of causes to hair thinning. All right. If you have a brief, really high fever and it's not really understood totally why, but there must be something related to this high temperature and the maybe inability for the follicle to function properly, all right, on the scalp, right? Because when you get a fever, it's really the head that gets really hot, right? There's a lot of sweating from that area, so that has something to do with it. But acutely high fever can be associated with hair thinning. Surgery, all right, if you have surgery, you may not grow hair back in that place, or maybe it's not as good at growing anymore. Severe emotional trauma, all right, is also associated with hair loss. Certain drugs, all right, you don't have to memorize all these drugs, but there's a variety of drugs that are associated with hair thinning and hair loss. Protein deficient diets, definitely, because the hair follicle, the dermis really needs protein there, okay, for that hair follicle to be at its best, all right? So protein deficient diets can cause hair thinning. And this situation here is something called Alopia Areata, and this is a really specific situation here where what ends up happening is the immune system attacks the follicles, all right? This would be considered part of an autoimmune disease. Autoimmune diseases involve, something's wrong in the immune system where the immune system starts attacking self cells, all right? So the immune system starts attacking your own cells, all right? And so this is a pretty specific one here where the immune system is attacking the hair follicles, alopecia areata. Keep in mind, most autoimmune diseases are seen in women. That doesn't mean men cannot get autoimmune diseases, because they can. It's just that for some reason, and it's not really well understood, but most autoimmune diseases, many of them seem to afflict women. All right, so that's good on that. Okay, the next part deals with glands. Definitely a high yield topic here, all right? So we're going to talk about the glands of the skin. So sweat glands. Now, they're also called sudoriferous glands. I will not call them that, though. Now, there are two kinds of sweat glands. We have eccrine sweat glands and apocrine sweat glands. For these, okay, for your question relating to these, definitely need to know the difference, all right, in terms of What type of secretion comes from each of these? That's one thing you want to know. What type of secretion comes from these? And where are these? Okay, so you'll need to make sure you have your locations for these straight. And also the function of these. Okay, so 3 things there that you want to focus on for these 2 types of glands. You want to know what kind of secretion comes from them, the location for each of these, and the function for each of these. Okay, so we're going to go through that. These glands, of course, are going to contain myoepithelial cells. Remember, myo means muscle. All right, so basically these are muscle cells around that are also epithelial in nature, okay, that are going to surround these glands that are going to help cause these glands to secrete. Okay, so the first type is the Eccrine gland, also called merocrine. It is the most numerous type of sweat gland, and here's where you're going to find it. Okay, well, let me just say this. Eccrine glands are everywhere, all right? They're really everywhere, but they're most abundant on the palms of the hands, the soles of the feet, and the forehead. Now, what is the function of these? These are the sweat glands that we talked about when we talked about thermoregulation, all right? These are the sweat glands everybody thinks of when you're sweating, right? When you're too hot and you start to sweat. It's these eccrine sweat glands that are functioning. Okay, so these glands are going to be regulated by a part of the nervous system called the sympathetic nervous system. We'll distinguish between sympathetic and parasympathetic nervous system later on, but for now you should just kind of keep in mind that the sympathetic nervous system is associated with excitatory functions. So sympathetic nervous system stimulates the body. And so it's this part of the nervous system that's going to stimulate eccrine glands to sweat in response to a thermoregulation demand. All right, so you know location, all right, you know function. Function is thermoregulation. Now what's in it, all right? You should know what's in the sweat. Okay, what's in this secretion? What's it made of? Well, it's mostly water, but you will find some other items in there. Okay, so salt. Remember, we are doing excretion through the skin as well, so you do get some excretion products. All right, so you do get some waste that come out in this secretion. All right, notice here, vitamin C. All right, vitamin C. So this should tell you something. All right, a lot of people take vitamin C supplements. I'm not saying that's a bad thing, but just keep in mind that vitamin C is one of these vitamins that if you have enough of it, that's all the body's going to use. All right, you don't use any extra. So if you're taking a lot of extra vitamin C, unless you're deficient in vitamin C, that's not really helpful, right? You're not going to use that extra because vitamin C, whatever extra you have, is it's excreted. All right, we sweat it out. You don't use that extra. Dermcidin is another one, kind of like defensin. We mentioned something called defensin earlier. Dermcidin is a microbe killing peptide. All right, this is something that we make, and it's going to be secreted through the sweat to function in killing bacteria on the surface of the skin. Okay, bacteria that we don't like, right? So there's good bacteria and bad bacteria. Good bacteria we keep. It has a symbiotic relationship with us. So we have this good bacteria that exists on the surface of our skin. And that good bacteria helps what it does is it competes with bad bacteria. So if you get bad bacteria coming around trying to invade into the skin, the good bacteria on the surface of our skin will battle with or compete with that bad bacteria. All right, and a lot of time our good bacteria is going to win that battle, and the bad bacteria will not be able to get in. All right. And basically when I say they're battling for nutrition. And so our good bacteria will eat up all that nutrition so that the bad bacteria can't have it, all right? In addition, right, we have this dermcidin, which will be secreted to help kill off any of those bad bacteria, okay? But the dermcidin is damaging to our own flora, all right? Flora refers to this good bacteria that I'm talking about. So dermcidin does not affect our own good bacteria or our own flora. Okay, so you should know the secretion, the location, and function of the eccrine gland. All right, now remember, eccrine gland is going to be like a coiled shape, and it's going to secrete through a duct all the way out through the surface of the epidermis. And here's a picture of it. Again, it does have this sort of coiled-like shape. All right, it's going to be coiled. Another picture of it, here you can see, again, that these glands are going to have direct secretion out of the skin by way of these ducts. So the second major type of gland is the apricorn sweat gland, apricorn. Now this is completely different, all right, completely different. In location, it's different in function, it's different in what kind of secretion it produces. So where is it? All right, we really find this in limited areas. We find this in the axillary and anogenital areas, the areola of the breast, and the bearded areas in men. Okay, so very specific locations for these sweat glands. What is the secretion type? What is the secretion like? Okay, the secretion is much different than the eccrine gland. All right, apricorn is going to be much more thick. It's more viscous, and it has a milky or yellowish sort of consistency and color to it. Okay, it's more milky and yellowish, and the reason it looks like that is because it has much more protein and fat in it. Okay, so your secretion here is this thick fluid that's abundant in fat and protein. So basically what we're doing is we're excreting. Remember, the skin does excretion. So this is basically one of the functions of this gland. Now, the functions of this gland are actually really interesting and are currently being studied, all right? It's not totally understood what the function of this gland is, but there are a lot of theories out there. So one theory is, well, of course, excretion, okay? Now, what's happening here is that this secretion is really nutritious, all right? Because it has all this lipid and protein in it, it's nutritious to bacteria. So remember the flora, the natural flora that we have in our skin, that good bacteria. That bacteria, this is another reason we have a symbiotic relationship with that bacteria, is that bacteria love this secretion, right? It's highly nutritious. So bacteria will break this down. It will consume this secretion. And now one of the metabolic byproducts of bacterial metabolism is the production of an odor. All right, when bacteria are eating, when bacteria are metabolizing things and breaking things down, the byproduct is oftentimes an odor. So this is what the cause of body odor is, all right, is that bacteria are breaking this stuff down, okay? So that's what leads to body odor, okay? So again, what's the function, right? What is the function of this stuff, all right? You know, like it says here, really the function is unknown, okay? But it's possible that, well, of course, excretion is a function. It's also possible that, hey, you know, we're maintaining this symbiotic relationship with our natural flora, right? We're actually feeding the bacteria there. Another really intriguing proposal or theory for the function of this gland is that it's basically secreting pheromones. All right, and so they serve as a sexual attractant. And, you know, one reason for that belief is that they begin functioning at puberty. All right, so right when our sex hormones are starting to be synthesized and secreted at a higher rate, all right, then we start to see an increase in the activity of this gland So there is some sort of relationship here, it is thought, between the secretion of these glands and a sexual attractant, right? These pheromones. Pheromones, basically, you can't really, it's basically like a sense. It's like one person may be able to smell some sort of scent on someone else, but another person can't smell that same smell, all right? It's basically like some sort of attractant. All right, so that's kind of an interesting function for the sweat gland. Keep in mind, this gland does not function in thermoregulation, right? Okay, what about some other apricorn glands? I'm just going to mention them briefly. We have ceruminous glands, which these are located in the ear, and they secrete cerumen, which is earwax. All right, what is the purpose of this? Well, it helps to waterproof the ear canal, and it helps inhibit the entry of bacteria. It's hard for bacteria and foreign material to get through that very, very thick cerumen. Then we have mammary glands. Mammary glands are apricorn glands, and these are going to secrete milk during lactation. Picture of sweat glands. Remember, you're going to see simple cuboidal, all right, surrounding a lumen here for our glands. Sebaceous gland. So the sebaceous gland, we've talked a little bit about before, I think. Sebaceous gland is going to be attached to the hair follicle. So therefore, it secretes into the hair follicle. And secretion is called sebum. So again, do not confuse this with a eccrine gland, all right? It's not a sweat gland. I mean, it doesn't secrete sweat, all right? It secretes sebum. So sebum is a very oily secretion, and what is its function? Well, it does have bacteria-killing properties, all right? It is sort of again, we're going to see all along that our bodies have natural defense mechanisms, right? The body is always going to attempt to heal itself, all right? It's natural to do that. So again, we have these antibacterial functions here, a lot of them here in the skin. And so also the sebum helps to lubricate the surface of the skin and the hair, all right? So it helps soften the skin and hair. Here's a sebaceous gland, all right? Remember, it's attached to a hair follicle, all right? And the sebaceous gland secretes through the hair follicle. You can actually see that there's a little duct here coming from the sebaceous gland, and that's where this sebum is going to be secreted through and into the hair follicle. So it comes out through there. Another picture of a sebaceous gland. So we're just seeing here another hair follicle. And again, the sebaceous gland attached to their hair follicle. All right, you can see them here, right? Remember, sebaceous gland attached to the hair follicle. Your eccrine gland or sweat gland is not going to be. Okay, this leads us to an interesting condition called seborrhea. Seborrhea is something that you find in infants. Maybe you've all seen this before. So what you see is it looks like a dry, scaly appearance, okay, which usually is going to be seen on the head of this infant. So what is the cause of seborrhea? Well, look at the name, seborrhea, sebaceous, all right? It's caused by temporary overactivity of sebaceous glands. Now think about this. Why do you think you would have this symptom here of scaly, dry, flaky skin if our problem is that we're having an increase in sebaceous gland activity? That means we're having an increase in sebum production and sebum release. So sebum is an oily secretion. Why would this be dry here? All right. The reason is, again, remember, the body is going to respond to whatever's going on. The body is going to try to compensate. Okay. If something's going wrong, remember homeostasis. All right. If there's a problem, the body is naturally going to try to compensate for that problem or change that problem. So yeah, what we see here is the body is responding to this increase in sebaceous gland activity by increasing keratinization. Okay, so that's what's happening. That's why you see this appearance here of the skin, is that we're having an increase in the rate of keratinization, meaning we're killing cells off faster, so we're shedding faster. And so what you're seeing is more dead cells here, more dead keratinocytes up here, and the body's trying to speed up this flaking off process. All right, so that's why it looks like that. Okay, so seborrhea. And seborrhea, they don't treat it. I mean, you can, but it's considered to be a self-resolving condition, which means it'll correct itself. It'll correct itself. All right, so let's talk more about pathology. The rest of this has to do with pathology. All right, so burns. We're going to talk about skin cancer and burns. A little bit about burns first. Or no, actually, we'll talk about skin cancer first. All right. So as we mentioned before, there's such a wide variety of conditions that can affect the skin. That's why we have a whole subfield of medicine called dermatology to address all of these conditions of the skin. And remember what I said about, when you do your physical inspection, right? You do your head to toe inspection of that person, and you're going to look at the skin, because the skin can reveal what's going on inside. Since we can't see the inside of the body, we can look at the skin to maybe give us some clues as to what might be going on inside. All right. Now, skin cancer and burns. All right. Let's get into these. So skin cancer first. All right. So most skin tumors, if you get a tumor on the skin, remember, a tumor, what is it? It's basically a collection of cells. It's a mass, right? It's a mass of cells that are dividing out of control, right? They're dividing out of control because there has been some sort of DNA mutation, which is causing these cells to divide out of control, and it causes these tumors. Tumors can be benign, or they can be metastatic, right? If it's benign, it's considered not cancerous. Okay? If it's benign, that means it's not going to spread. It's not going to spread through the bloodstream. It's going to stay where it is. Okay, so this is why benign, if you're going to have a tumor, it's better to have a benign tumor, because it's not going to spread through the bloodstream. Okay, it basically doesn't get too much bigger. It's just a little less worrisome. Now, a metastatic tumor, on the other hand, this is the one you worry about, because this is the one that will spread through the bloodstream, go to other locations, and cause tumorous cancerous situations in other parts of the body, which can be very dangerous. Now, as far as the skin cancers go, by and large, pretty much all of them, actually, yeah, I mean, I'd say pretty much all of them, all right, are caused by one problem, and that is excessive sun exposure. All right, so again, this is an example of something that you can prevent. All right, this is a cancer that you can definitely prevent. No one has to have this. All right, you've got to protect the skin from the damaging rays of the sun. Okay, the UV light, too much of it is going to cause our melanocytes to increase production of melanin, right? Now, if you're damaging your keratinocytes from this UV damage, what are you doing? You're killing off your keratinocytes. Okay, you're killing them off. So what this does is it causes an increase in the activity of stratum basale, for example, so that you're going to be making more cells, right, to make up for all those cells that you've killed off. So if you're increasing the incidence of having to do mitosis over and over again, you're increasing the possibility of there being some sort of DNA mutation, right? The more cell division you do over a lifetime, the more you're increasing the risk of there being a DNA mutation. All right, so that's the deal. All right, now where are you going to find these skin cancers? Well, most often on the really exposed areas of the body, right? Like the head, face, neck, hand area is where you will find a lot of the lesions associated with skin cancer. Of course, skin cancer is most common in fair-skinned people. Why? Because fair-skinned people don't make very much melanin. They're able to protect their skin as well. Okay, so they're more likely to have damage from the UV rays of the sun. So they're going to be much more commonly at risk for skin cancer. All right, and then the elderly, because the elderly have thinner skin anyway. All right, and now again, it's one of the most common kinds of cancer. It's also one of the most easily types of cancers. With any cancer, detected early for a better outcome. Risk factors, really UV radiation. Okay, now you can get cancer from frequent irritation of the skin, but that's much more rare. Okay, most of the time it's due to too much sun. Now, there are 3 kinds of cell cancers that we're going to talk about. For your questions on quiz or exam, you will be presented with a clinical scenario. All right, a lot of your questions now are going to be more like this. So you'll be presented with a scenario, a story, where you'll be given a patient's symptoms, all right? And you'll be asked to identify what the condition is. Okay, so for sure on the quiz and exam, you'll have a question that's defining or describing a skin cancer scenario, and you'll be asked to tell which one of these is it. Okay, so let's look at each one of these cancers then. The first one is basal cell carcinoma. Why is it called basal cell carcinoma? Because the cells of the stratum basale are the ones that are proliferating or dividing out of control. Okay, so it's the stratum basale cells that we're dealing with in this. Now, if you're going to have any kind of carcinoma or skin cell or skin cancer, this is the one you'd want to have because it's the least malignant. All right, it is least likely to invade other parts of the body, least likely. And fortunately, it is the most common one. Okay, so fortunately, the most common skin cancer is the least malignant. Okay, so it's really not a big deal. All right, if you get this, just as long as it's detected early, you can get rid of it. All right, you just get rid of the tumor and you're good. All right, again, it says here 99% of cases are cured just by removing the tumor. Okay, now the stratum basale may start to invade a little bit into the dermis and hypodermis, but this is going to be a very slow process. So typically a person is going to have this tumor removed before it gets to that point, okay? Because fortunately, skin cancers don't hide, all right? You can see them on the outside of the body because there will be some unusual lesion there that you clearly see. So a person is going to be more likely to go, get this addressed and see, hey, what is this lesion on my skin, right? All right, that's, again, why skin cancers are a little less dangerous because you can see them, you're alerted right away that there is some problem, all right, because you can see it. What does it look like? It looks kind of like this, all right? So basal cell carcinoma, all right, usually what you'll see is that the lesion, and again, most commonly these are like on the face area, all right, you will see a central indentation, all right, you'll see a central indentation there, okay, for basal cell carcinoma. Usually there's not a great deal. Here's another picture. Now this one shows that this one is more discolored. This is a more severe situation. Usually it doesn't look as colored like that. Okay, but you may see some coloration, but a lot of times you won't necessarily see very much discoloration at all. Okay, it is the most common type. Seldom metastasizes. Again, it's really only going to spread if you let this go for a long time. It's a cancer of the stratum basale. All right, and again, usually be kind of a small lesion, sort of a shiny lesion, and it will have a central indentation or a central depression. The second one is squamous cell carcinoma. So squamous cell carcinoma is a little more dangerous. All right. This one it is capable of metastasis more quickly compared to basal cell carcinoma. And this is going to be a cancer or a tumor involving cells of the stratum spinosum. Okay, so that's called squamous cell because what are keratinocytes? Keratinocytes are making up the stratified squamous epithelial, right? So that's why it's called squamous cell carcinoma. Now, how does this one look? This one's going to be more scaly, and it is going to be red, okay? And it looks like a little papilla, like a bump, all right? Again, on exposed areas like the scalp, ears, often seen on the lower lip, the hands. Now, even though it's capable of metastasis, there's a good prognosis. Again, why? Because you can see the lesion, all right? So you're going to go in and get it checked out, and it's going to get removed. So here's a picture of it again. This one is more red, okay? And it has more of a scaly appearance to it. Again, here's one on the hand. Again, you can see the redness there. Again, it's from keratinocytes of the stratum spinosum. And, note your common locations. Again, they're going to be like exposed areas. And again, unlike the basal cell, it has a raised appearance to it. It's like a papule, okay? And again, pretty good chance of recovery with early detection, okay? But if you don't, this one will metastasize. Okay, here's the big one, right? The big one. So melanoma is the worst skin cancer. It is a very dangerous skin cancer. It is very rapid. It will move very quickly. It can spread. These cells here will divide like crazy and move very quickly. So what is melanoma? Melanoma, like melanin. So it's a cancer of melanocytes. We have melanocytes dividing out of control, and they're going rapidly. So you should know how this is diagnosed, all right? It goes by what's called the ABCD rule. And so this is what you're going to use to identify whether or not you have melanoma. Now, with melanoma, you have to in order to give a diagnosis of melanoma, you have to have all 4 of these, not just 1 or 2. All 4 of these, okay, must be present in order to give a diagnosis of melanoma. If you have 3 of these, but you're missing 1, you can't give the diagnosis of melanoma. All 4 have to be here. So what are these 4? Asymmetry. Okay, so the sides of the lesion will not be symmetrical. Okay, they will not match. They will have an asymmetry. Border irregularity. Okay, so the borders of the lesion will have an irregular look to them. Okay, there might be like indentations in the borders of the lesion. Color. So the color is going to be dark. Right? It's going to be dark because what are we doing? We're having melanocytes divide control. So we're having a lot of melanin. Okay, so it's typically going to be very dark. It might look so dark that it actually looks blue. Okay, or have even shiny red. Diameter is the 4th one. All right, so the lesion must be larger than 6 millimeters in order to be considered melanoma. Now, you may have a situation where, let's say, we have all these first 3 satisfied, right? But it's not larger than 6 millimeters. Probably, most physicians will go ahead and say, yeah, it's melanoma, and let's get in there before it does get larger. Okay, so that often is the case, but majority of time it's going to be large enough anyway. Here's a picture, right? Really obvious. Okay, look again. We're seeing asymmetry. Look, this side is not the same as this side. Border irregularity. If you look closely, there are some indentations here on the borders. It's dark. And yes, it is larger than 6 millimeters. Okay, so again, here's another picture. And again, I really said most of this. Now, here's the problem. If melanoma is allowed to metastasize, if you don't catch it early enough, it can cause death, okay? Because what melanoma likes to do is melanoma really likes to go to places like the lungs. All right, so, you know, and it can be just absolutely fatal there. And speaking of lungs, I forgot to mention squamous cell carcinoma, just as a side point here. Squamous cell carcinoma that we already talked about is actually a skin cancer that is comorbid with people who have lung cancer. For some reason, and there is a reason, but lung cancer patients are often prone to getting squamous cell carcinoma, right? Just a side point. So back to melanoma then. Again, yeah, this one really likes to spread, and it likes to go to the lungs and other places, not just the lungs, but pretty serious places, and cause death, right? So yeah, this is a skin cancer you can actually die from. So risk factors, well, genetics, okay, genetics, and that's really the case with most kinds of cancers, because again, we're dealing with DNA mutations. DNA mutations cause cancers. So if you have a family history of it, you know, there may be a genetic predisposition for you to develop a certain kind of cancer, okay? Now, it says highest incidence in men, but I want you to know women get it too, all right? Women get it too. You know, I think what's important for you to understand is really that the highest incidence of this is in fair-skinned people, okay? People who are very light-skinned and end up going out in the sun too much and not protecting their skin. These are the people that are really at risk for getting this terrible melanoma. Okay, and I want to mention something else about this melanoma is that another reason why melanoma is allowed to have time to metastasize is because a lot of times these lesions are in places that a person cannot see. So, for example, you can get these behind. You can get these like behind your neck, or like at the upper part of your back, or like, you know, behind your shoulders. And you know, if you're a person that you don't really see that, especially in an elderly person who doesn't really see that, they may have to have somebody else bring it to their attention. Like, hey, you have this really dark spot here on your back. Did you know about it? You know, the person didn't see it. Okay, so, you know, in some cases, especially in the elderly, you know, it may go for a while without detection, and that can be one reason for that individual that it would be able to metastasize very quickly and become fatal. All right, burns. A little bit about burns here. All right, it's funny. It's like this. Okay, well, it is the leading cause of accidental death. That's not the funny part, but what I find funny is this first line here from your textbook. It's like, what causes burns? So, yeah, we know what causes burns, all right? Okay. Now, if you have severe burns, most likely the reason for that is due to the loss of fluid, all right? Because you don't have your cells, right? Your cells have burnt off, so, you know, you're not able to maintain osmosis, are you? Okay, so you're going to have fluid loss. Infection, right? You no longer have that very protective skin. You no longer have these macrophages there. You know, you've burnt it away. So infection is a big problem, okay? And again, you know, damage is caused by, well, we've basically burnt off our proteins and our cells, right? Dehydration, right? Because you have a loss of water. And of course, we can't do like things like simple diffusion, right? Because our plasma membranes have been destroyed, so you're not able to maintain electrolyte balance. So there are three classifications for burns. So you'll probably have this is kind of a basic question about this. First degree, second degree, and third degree. All right, so first degree burn means only the epidermis has been damaged, only the epidermis. Okay, so this will be seen as redness. It will be seen as edema, which is swelling, and you're going to have pain. It's going to be pretty painful. But guess what? If it's just the epidermis, all right, we're going to have the ability to heal that pretty quickly because epidermis, right, is epithelial tissue. So epithelial tissue is highly regenerative. Okay, so first degree burn, you're going to be okay. Second degree is a little more serious. So this is when you have epidermis and upper dermal damage. Now here's where you'll see blisters, right? Remember that a blister means there is separation between the epidermis and the dermis, right? So yeah, this is where you're going to see blisters, all right, between the two layers. Okay, so but we're going to have a problem here with loss of cells in the epidermis and the upper dermis. And again, blisters and pain, right? Pain, because we have all of our free nerve endings out there. Remember our free nerve endings? For both first degree and second degree, we still have the lower dermis. We still have that. So that means we still have some sensory receptors intact, including the free nerve endings that are good at detecting pain. Okay, so we still have our lower dermis in this second degree, and we have our entire dermis in first degree still intact. So we will have pain, all right, in both of these because our free nerve endings are still there. Third degree is the worst. So third degree is the entire thickness. It's often called full thickness burn. So this means all of the epidermis and all of the dermis, all of it is burnt off. All right, you may even have hypodermis burnt off. In this case, you're going to have like really red looking area there. It can be sort of a charcoal look, sort of like a blackened or a charcoal grayish white look to it. You don't see any edema, and guess what? As severe as this is, there's no pain. All right. Now, of course, if muscle has been penetrated, yeah, you've got a lot of sensory receptors there in your muscle, and that's going to hurt like crazy. But, as long as you haven't penetrated muscle, there's not going to be pain. Because why? Well, you've destroyed all of the epidermis and all of the dermis, so you've destroyed all of your pain receptors. There are no pain receptors there to detect pain. Okay, so as strange as it is, it's the worst one, but as long as muscle hasn't been burnt, there's no pain. All right, usually skin grafting will be required for this. You'll need to take other skin and place it over the area. You'll need to monitor the person to make sure they're getting enough fluids and electrolytes. Here is a comparison, all right, in these three types. All right, you've got first degree here. First degree is like a sunburn, right? Second degree is more serious. You will see reddening, much more red. You will see blisters. You may even see scarring. And then third degree, is the entire epidermis and dermis. And it's going to be, black or charcoal look. Okay. Just some more examples. So this person here has a first degree burn here. Okay. Just a little bit of redness there. They'll be fine. Now, second degree, remember second degree is when we see blisters. All right. So you can see these blisters here. And then here is a third degree, as you can see. So burns, again, how are we going to treat it? Well, first you need to remove any burned skin. You don't need that anymore. That's called debridement. Okay, you're going to use antibiotics on the person, skin grafts. All right, so we're ending here. We're ending this, and I like to end with the developmental aspects of that system. So with the skin, all right, from infancy to adulthood, all right, you get a thickening of the skin and you get an increase in subcutaneous fat. You get an increase in gland activity, all right, from infancy to adulthood. This increase in gland activity actually can lead to acne, all right? So that's why adolescence, okay, and up to early adulthood, the incidence of acne is more prevalent, okay, because you have more gland activity. Right? And again, what do we have on our skin? We have these bacteria that like to metabolize all that stuff. Okay, so if you have an increase in bacterial metabolism of that stuff, you're more likely to have acne. Obviously, the optimal appearance of the skin and hair and nails is 20s to 30s. After 30, we start to see a decline in the integrity of the skin and the hair. You start to see more dry skin, okay? As you age, the skin does get drier. Why does it get drier? Because you're having a decrease in gland activity. Remember that as we age, everything slows down. Okay? When you're young and you're developing, everything's increased. When you start to age, everything's decreased. Okay? So we're having a decrease in sebaceous gland activity, which is causing drier skin. The older you get, the skin will become more dry and itchy, right? We're not secreting as much sebum to provide that lubrication of the skin. If you get epidermal damage, healing slows down. Subcutaneous fat, we get a loss of that. It sort of starts to deteriorate away. And so in the elderly, of course, that helps explain why they're more prone to getting hurt when they fall down, because they don't have as much cushioning. So they're more likely to have increased bruising, all right? You will see more bruising in an elderly person if they fall or whatever. You have a decrease in the formation of elastic fibers and collagen fibers, all right, which again, is why you want to try to take skin products that have elastin and collagen in it to help bring new elastin and collagen into the dermis, all right, because that will help prevent the appearance of wrinkles, all right. Now, another thing about wrinkles I want to mention, another cause to them, related to collagen. And you know that the dermis is made of dense, irregular connective tissue. That means the collagen is arranged in a haphazard pattern. But over time, what happens is these collagen fibers are actually going to end up taking on a more dense, regular pattern. Okay, so the collagen fibers start to become parallel. All right, they're no longer arranged in an irregular fashion. And again, that's what causes the wrinkled appearance. Okay, you do have an increased risk of cancer as you age for skin cancers because, over a lifetime of doing mitosis, you're increasing the possibility of there being an error in DNA synthesis, leading to a DNA mutation. That's one thing, okay? But you also have, once you're older, you have decreased mitosis in all cells, all right? So, you have a decreased number of melanocytes, you have a decreased number of white blood cells and macrophages, okay, which can help contribute to the onset of cancer. And then we have hair thinning. So how do we delay aging? I don't know, but if any of you know, let's talk about it, right? But some basic ideas here. Of course, the most important thing you can do to delay the signs of aging of the skin and to protect the skin from cancer is UV protection. Of course, staying hydrated, right? Staying hydrated is good for every part of the body. And good hygiene, right? Yeah, like clean the skin off, right? And good nutrition. So that's it. That is Integumentary system. And I hope that some of that was interesting to you. We will be having a quiz covering this here soon, and I'll let you know when I have that quiz up and ready for you. All right, and that does it. Thanks, everybody. Have a great day.